Hi everyone, I'm Stephanie Bryson, and I'm coming to you from Portland State University in Portland, Oregon. My task today is to talk briefly about some of the challenges we face in the U.S. with regard to community practice. And the question is whether I can do this in 5 minutes. I'm going to argue that there are three main challenges to community practice in the U.S. marketization, criminalization, and professionalization, including medicalization. But first, to give you an idea of the percentage of social work programs with a significant macro or community practice focus, this is the distribution of 250 MSW programs that are accredited by the Council on Social Work Education. And these are the 250 MSW programs in the US. So you can see that the majority of programs, 70%, emphasize clinical or direct practice or advanced generalist practice. A small number of programs offer a specialization in community-based practice or policy practice. Similarly, when we look across fields of practice specializations in MSW programs, we see that they mostly cluster in child welfare practice, aging, and some variation of mental health or healthcare. The same is true for BSW programs. And evident in these statistics is what several scholars, including Reich, have described as the impact of neoliberalism on social work. The marginalization of macro practice, the professionalization of the workforce, and greater emphasis on the individual rather than structural change. And you can see that in all of those areas of practice. They're quite medicalized and individualized. Neoliberalism individualizes problems and privatizes services with a heavy reliance on individual responsibility and accountability. It promotes the reduction of government spending and privatized market-based solutions to social issues. I want to use an example that comes from my colleagues Gita Mehrotra, Erica Kemble, and Stephanie Wahab to trace some of the ways in which neoliberalism and the combination of neoliberalism, criminalization, and professionalization that my colleagues refer to as the braid that binds us. I want to trace the ways in which this has diminished or made more challenging community-based practice in the U.S. So the example will focus specifically on domestic violence work. And in this article, my colleagues argue that this combination has marginalized social and structural change, has supported the carceral state and mass incarceration, has fetishized physical safety, and has constrained who can do domestic violence work. For example, the privileging of women's individual efficacy within the neoliberal agenda transformed the battered women's movement from a social change movement rooted in feminisms to a service-focused, individualized treatment modality. And it also criminalized domestic violence and professionalized the workforce that can treat domestic violence. DV funding has increasingly become tied to the state through the Violence Against Women Act, which shapes the types of initiatives that receive funding. In a neoliberal climate, organizations seen as providing the most efficient intervention services receive the most public funding, which results in small grassroots-oriented programs being absorbed by the larger nonprofit industrial complex. And this has major implications for the ability of social workers to do community-based practice in the U.S. Moreover, the consequence of framing domestic violence as a criminal issue rather than a human rights, civil rights, or public health issue limits the structural analysis of its depth, breadth, causes, and consequences. Increased criminalization of DV has had a range of unintended consequences for a number of marginalized populations, including women and men of color, undocumented immigrants, poor people, transgender people, queer people, women with disabilities, and sex workers. With regard to professionalization, when the DV movement started, it was led by women from the community. It emphasized collective structures, self-help, peer-to-peer counseling approaches. All aspects of the work were designed to reflect feminist values. And since formalized funding, particularly at the state and federal level, have taken over, this has meant that DV agencies have become increasingly professionalized. Accountability to funders requires organizations to provide endless financial records, case notes, and program evaluation results, and it requires a certain level of training. It's no longer a peer-to-peer model. And finally, in a related note, feminist DV scholars have noted that unwieldy social goals rooted in changing structural conditions are made manageable by creating services and systems to promote incremental change, represented here by the health impact pyramid. So clearly, the bottom of the pyramid, if we were to intervene on those factors, we would bring about the largest impact. However, social work has increasingly focused on those very individualized top two tiers of counseling and education and clinical interventions. By way of recommendations, Mehrotra et al. Argue that as we look for transformative and innovative approaches to ending DV, we must challenge the notion that the solutions reside solely in the state or the science. This can be achieved by forming broad-based coalitions, centering the needs of the most marginalized in communities, developing alternatives to criminalization rooted in restorative justice, promoting funding alternatives such as funding collaboratives, and funding research that explores the social and structural determinants of domestic violence.